Hi everyone. As promised, Dr. Kiva Hartley has joined me. Kiva is at a very exciting time now for herself. She's due to open her own clinic, hopefully next week, we hope.
Fingers
Called
crossed. Yeah.
Menopause Health. So we're going to have a general chat, but Kiva wants to talk about progestin versus progesterone and so on. Thanks, Kiva.
Thanks, Sallyanne. It's great to be chatting to you. Always great to be talking about anything to do with menopause. So I'm happy to be here. So it's hard to know where to start because progestogen and progesterone, and it's such a really, it's a big area that I feel a lot of people get really confused about. So I thought it was worth maybe tackling and going through maybe some of the basics and trying to answer some of the questions that I would get a lot in my own practice.
Yeah.
So progesterone is a hormone, and it's usually produced, or it's mostly produced, by our ovaries. So our two little glands either side of our womb that make estrogen, progesterone, and testosterone. And the reason we make progesterone, so we make most of it in the second half of our cycle. So that's the 2 weeks before you get your period. And it's made from, if you think when you ovulate, which is in the middle of your cycle, when you ovulate, you release an egg, and the egg has been sitting in a little capsule. When that capsule releases the egg, it's that capsule that starts to make progesterone for you. And progesterone will encourage the lining of your womb to thicken and change so that if you do become pregnant, the embryo can then implant into it. So it makes it really hospitable to pregnancy. But if at the end of that 2 weeks, if you're not pregnant and nothing has happened in terms of fertilization, your progesterone levels will fall. And that fall in progesterone is what gives us a period then. So the lining, that kind of scaffolding that has been protecting your lining, comes away and you have a period. So that's progesterone's main role. What I think makes people really confused is the names on all of this. So you have progesterone. So I was told to enunciate really carefully when I'm doing this because you can kind of, it's so confusing. But progesterone is our natural hormone that our ovaries produce. Progestogen, they're called synthetic progestogens. So the reason they exist is because if you think back in the 20s and 30s, some scientists, don't ask me who, but somebody won a Nobel, I think, prize for isolating and discovering that progesterone was a thing. And then they set about trying to kind of create it in a lab so that they could give women progesterone, but they weren't able to make the molecule. And the other thing that was really difficult for them is that progesterone, our natural hormone, is a really big molecule, the difference between a marble and grain of rice or whatever. It's a big molecule. So the problem is when you give somebody progesterone, because it's so big, it's really hard for your body to absorb that in through your system and get it into your system to where you need it. So they came up with these synthetic, man-made progestogens, which are good. They do a similar job, but they're not the same as progesterone. So we have about 20 or 30 or maybe even more different progestogens, kind of like different brands of car, I guess. They all kind of have the same purpose, but they're all slightly different to each other. And so they're often built into a lot of our HRT.
What would be the most common ones, Kiva, so ladies can relate that, like Dufaston or Dufaston? How do you pronounce that? That'd be a very popular one.
Pronounce that whatever way you want. Sometimes I say Dufaston, sometimes I say Dufaston. It's like vaginal and vaginal, and So Dufaston is dydrogesterone. So dydrogesterone, or Dufaston, is the most similar chemically. Its structure is the most similar thing that we have to our natural progesterone in terms of all the synthetic progesterones, all these fake synthetic progesterones.
Synthetics.
It's probably the safest for breast cancer, we think, as well. So dydrogesterone would be what's in Femiston, for example. There's another one, norethistron acetate, that's in Everil Conti, which a lot of women would have heard of as well. And that's through your skin as a patch. So the reason we give progestogen, the reason we're giving people this second hormone in addition to estrogen at all, is because we want to protect the lining of the womb. So if I was to give you estrogen and you have your womb, you haven't had a hysterectomy, and I give you estrogen, the way the lining of your womb will respond is that it will thicken and grow, and it will thicken and thicken and thicken. You might get lots of bleeding, but also over time, you can actually get a risk of the cells inside your womb becoming abnormal. And it depends what you read, but some of the studies even say up to a fifth, about 20% of women after a year of estrogen on its own, if they still have their womb, will actually develop some abnormal cells. That's called hyperplasia. The lining gets sort of thick.
Yeah.
And if left like that, over time, that can turn into womb cancer. And that's why we give you progesterone. It balances that. It blocks the action of estrogen on the lining of your womb. Keeps you safe.
Yeah. I'm glad you've said that. There's always a lot of confusion about people think progesterone makes you bleed. But progesterone actually balances things. It's estrogen that makes you bleed.
Yeah, so estrogen will promote growth in the lining of your womb. Sometimes taking the progesterone away, because it's been there sort of stabilizing the cells inside your womb. When you take it away, you can get a withdrawal bleed. Yeah.
Exactly. So that's what I was saying. It's nearly like the bath plug, you know, when you women might think because they bleed when they stop progesterone, they automatically think it's the progesterone that makes you bleed.
Yeah.
But it's not, it's the taking away of it. Yeah. Okay,
exactly, great. Yeah. Yeah. So that's why we give it. So it's really important, like you said, for protection. And I think one of the worries that we have is that women might not understand why they've been prescribed the two hormones. They know that they feel better when they're taking the estrogen, and they sort of make a decision to stop the progesterone because it hasn't been explained to them properly. This is what you're taking this for. It's mostly to protect your womb. You really need to stay on it. So that's sort of why we prescribed it and what it's, you know, what it's used for. And there's different ways of prescribing it. So you can prescribe it in combination with something. So like the Everil Conti patch. I don't know why I keep patting my arm as if I have an Everil Conti patch on here. I do not.
You might be wearing one and we don't know.
Or here or down here, but you should be putting it here. So
I was going to say always below the waist, Kiva.
I know, here I am patting my arm, like you're totally confusing people. So it can come in a patch. So you can put it in combination with an estrogen. Or you can prescribe it you know, progesterone, when we use it for contraception, you can prescribe it as an injection. That's called the Depo-Provera injection. There's an IUD, or the intrauterine device. Mirena is the one that most people have heard of. So a small T-shaped device that goes into your womb, and that releases a small amount of a progestogen called levonorgestrel. And so that protects your womb. You can take your estrogen separately when it's being used for HRT, and it will sit inside your womb and protect your womb. So there's a load of different ways we can prescribe it. But what really catches people out then is the difference between these synthetic man-made progestogens and micronized or body identical or uterogestin progesterone. So it has three different names.
Way.
You know, So progesterone, so micronized progesterone or uterogestin, is body identical. So I think that terminology trips people up, and it's important to know that that all means the same thing. Micronized progesterone, body identical progesterone, uterogestin, all the same thing. And what we're talking about is how more recently, I don't know what year, but more recently, they were able to figure out how to make exactly the same compound as what your ovaries produce. Hence, body identical. It's exactly the same as what our ovaries produce. And that's uterogestin. Or the other name, as I say, is micronized. And the reason it's called micronized progesterone is because they took the big molecule. And micronization is when you basically pummel it, like you pulverize it, like putting it in a pestle and mortar, and you make it into, you break it up into tiny little pieces. It's hydrophilic, and so what you have to do is you have to mix it with oil, and that goes in a little gelatin capsule, and that all of a sudden they were able to give women this hormone that looks exactly like what their ovaries were producing, and all of a sudden they're able to absorb it now, and that's uterogestin.
Brilliant.
Because as you know,
game changer in hormone land, isn't it?
It is, yeah. And it is because although the synthetic progestogens are good and they're good at protecting our womb, they come at a cost a little bit, and they're not perfect, and they don't exactly mimic what we're used to naturally. So the good thing about micronized progesterone or uterogestin, whatever, is that it, in terms of when you look at safety risk in particular, it seems to be, by far, it seems to be the safest. So they've studied its impact on breast cancer, and there was a relatively recent French study looking at micronized progesterone with estrogen. I think for women I think they were within 3 to 5 years of their last period, and they took it for 5 to 7 years length or duration, and the impact it had on their breast cancer risk was minimal. So I think that's really interesting to know. Yeah,
Yeah, I'm always saying that to women, you know, especially if someone's starting from scratch with HRT and they're asking, you know, what's the best way to go? If you don't already have a Mirena, you have nothing. Like, absolutely, the safest way all the way, yeah? Assuming you
micronized progesterone all the way, yeah.
MP4, yeah definitely.
So it is well tolerated. And I think that's probably because our body recognizes it. It's like, oh, this is something I've had before. It's not aware that it's something that you're, you know, taking. Yeah. So going back to sort of the different ways you can prescribe these progestogens or progesterone. So usually they're given, if you're someone who's still having periods, we usually give them for 2 weeks out of the month to provide that protection. Then you stop them. And as you pointed out, you might get a period at that point. And then you go back on them 2 weeks later for 2 weeks, then you stop them, and so on. After a year of doing that, some women will be able to switch over to using it continuously. So they're taking a lower dose, but every day.
I'm glad you've said that, because there's some contradiction on that lots of people go, no, once you're still having periods, you have to stay on sequential. And I have always said, well, actually, no, I went on to continuous while I was still having periods a long time ago. It is okay to do that, isn't it, after the year? Yeah.
It's probably preferential. Like, ideally, we'd actually put everybody on continuous progesterone from progestogen from the very beginning. And the reason is that if you're taking progestogen every single day, your risk of womb cancer is lower. So it's just that bit better at protecting your womb.
And it's not powerful enough to stop the period either. Sure, it's not. You're still going to bleed if you want to.
Uterogestin isn't. Yeah. Now, for some women it is. It all comes down to, like, we're all kind of genetically different. And some women will be sensitive enough that they might be lucky and the periods would stop. But you're right, not everybody. You're right. Yeah. And I suppose the reason that we don't put everybody on continuous progesterone from the beginning. So if you're still having periods, your womb is still quite active, and so are your ovaries. You're likely to still be ovulating at times at least. And so if I put you on, you being like, if I put somebody on, you know, continuous progesterone when they're still having periods, they're really likely to get lots of breakthrough bleeding and spotting, which people hate. And so they'll stop their medication. They'll be like, this is not for me. I don't like that. I don't want to live with this kind of continuous bleeding. And so that's why cyclical,
though, doesn't it?
For most women, but it's hard. I suppose the younger you are and the more active your womb is, the more likely that is to be a real problem and not settle over time. And so that's why cyclical exists at all. This kind of every 2 weeks approach exists at all, is for that reason.
Would you choose Utrogestin, Kiva, over the Mirena if a woman didn't necessarily want contraception and she wasn't having bleeding issues? Because I know
I like this question, because so in, like, what you're getting at, I think, is the individuality of this. You know, I mean, most patients I see end up with a prescription for estrogen through their skin because it's the safest, and Utrogestin because it's the safest. Like, it's a no-brainer.
So if I was sitting in front of you now as a patient and I knew nothing about HRT, I was clueless, and I didn't essentially need contraceptive, and I wasn't having bleeding issues, would I be leaving with Utrogestin and gel rather than the Mirena?
So what if you said, I mean, in that case, yes, maybe, but that's where it comes in. If you say, like, you know, I'm worried about becoming pregnant and I'm still having periods up until a few months ago, and contraception's a huge deal, and I find it hard to remember to take a capsule, you know, every night, or I might find it hard to go on and off this thing. Or, like, some people prefer, say with Everil Conti, which is not your body identical progesterone built into it. But God, it's handy because it's just a patch, and you change it twice a week and off you go.
So off you go. Yeah,
that's it. Yeah. So I suppose you have to factor in what the person sitting in front of you, what their aim is, what they want to get out of their menopause consultation, what's important to them, what their values are, what their priorities are, and then you kind of prescribe and counsel and figure out a plan with them around that. Yeah. So it just depends. And the other thing to factor in, like, when we look at those synthetic progestins, all those different brands of car or whatever, all the different types, they all have slightly different characteristics. So some of them, for example, you mentioned a coil. So Levo or Norgestrel that's in your coil some of them mimic testosterone a little bit. And so they can be more likely to give you things like acne. They're less effective at reducing excess hair growth. You know, so you have to factor that in as well. If I have somebody with, like, I get dreadful, I have awful acne. So I love the thought of a coil because I I don't want to have a period anymore. And it's, but I'd be, so you have to kind of factor that in. I'd be worried about the acne side of things. Yeah, it's really, really individual. Yeah.
Okay. Yeah, no, interesting. I'm just curious because I know a coil is a really, really good option for HRT. Like,
certainly
it really
convenient,
is.
Yeah. And it's very effective.
From my own research as well, I love the additional benefits of micronized that we don't get with any of the others, which I'm fascinated by, such as it's protecting my brain, it's working with my nervous system, it's helping me sleep, it's protecting my bones. I mean, what else does it do, Kiva? You know more than me now here, so it's wonderful.
What doesn't it do? It's so fantastic. Yeah, no, you're right. So again, when we kind of break all these different options down for what you can use to protect your womb, and you're looking at micronized or body identical progesterone, it's anti-androgenic. So that means it's sort of doing the opposite to maybe what testosterone does. So it's good at not giving you acne as a side effect. It's quite good at kind of countering some of the excess hair growth that some women get as they move through menopause. It's tranquilizing, which is, maybe the wrong word to pick, but it's good at helping you sleep. Essentially, tranquilizing makes it sound like it knocks you out. It doesn't, don't worry, but it has a bit of a sedative effect. So it tends to improve sleep. 2 big studies.
And that's why we take it at night, by the way, because some women have taken it in the mornings and they're like, whoa.
They're white.
It does give you a lovely night's sleep.
Yeah, so there were 2 trials in particular looking at this, at a mixture of estrogen and micronized progesterone in particular. And they've shown that it really does, for the majority of women, it'll improve sleep. It's neuroprotective, so that's what you were saying. So it's interesting. It seems to help protect some of our brain cells and some of our synapses, like how our nerves communicate to each other in our brain. And they get wear and tear damage over time. And it seems to be protective from that type of damage. One of the really interesting studies that's going on at the moment is looking at using body identical, like micronized progesterone, for a thing called remyelination. So basically, if you think of your nerves, it's covered in a sheath like electrical wire that's wrapped in whatever electrical wire is wrapped in.
I know what you mean. Yeah.
Casing or whatever, and in conditions like multiple sclerosis, where we see damage to that, casing or that protective thing that goes around your nerve, that's called your myelin sheath. And in multiple sclerosis, that gets damaged and it disappears. So they're starting to use micronized progesterone for remyelination, so improving how the protective coating that sits on top of your nerves. It's interesting. Same for Alzheimer's, same sort of thing. So you get a buildup of a particular type of plaque in your brain, I think called amyloid plaque in your brain with Alzheimer's dementia, and utrogestin or micronized progesterone seems to slow that down. So it has really interesting potential, health benefits. And the last thing it does, that, if you can split all these different progestins out as well, you can, some of them have an action on your kidneys, and they help you in terms of water retention. They can actually counteract that. They're called diuretics, so they can help you to a small degree lose some excess water if you have some fluid retention, and by doing so they can actually be beneficial for your blood pressure. So it's been shown to actually be helpful for blood pressure. It's not very powerful. It's not going to drop your blood pressure, but it will keep it in a healthy range.
So what's not to like?
Well, that's the thing. I guess it's inconvenient because it's not, we don't have anything that it's built into estrogen with. We don't have a combination. Like if you could come up with one, that would be great.
Just take a tablet going to bed. Yeah. No big deal.
Yeah. Just for some people,
they might. Locker,
That's what I would do. Yeah. Stick it by your toothbrush, whatever you want to do.
Exactly. Kiva, talk to us, because we know that can also be used vaginally or vaginally, whatever way you want to pronounce it.
I never know. Yeah.
It's one of those words. When would you find that suitable? Like, or do you say to a lady, here you go, you can use this either way, or do you wait to see maybe if they have an issue with it orally? Because I'm aware, and correct me if I'm wrong, we don't get all of those extra benefits we're talking about if we use it vaginally. Yeah.
You're absolutely right. Yeah.
Okay.
And the reason is, without getting too bogged down into the science, but when you're taking progesterone, so your body identical micronized progesterone by mouth, it's metabolized, so it's broken down by enzymes in that are made by bacteria that live in your stomach. Then it goes through your liver and it's broken down by your liver as well. And when it's broken down, one of the byproducts, so your body breaks it down and sort of shoots off this other little protein. One of the things that happens when you break progesterone down in your tummy, you create this little protein. And it's that little protein, like an offshoot of your progesterone, that actually goes up and has an effect on receptors in your brain. When you take it vaginally, or vaginally, depending where you live, I suppose, when you take it vaginally, it does the same thing in the sense that your vaginal wall and like that environment will break down the capsule, the gelatin capsule. It'll absorb that progesterone, and that hormone will go in and protect your womb just as well as if you take it by mouth. Yeah. But the bacteria vaginally don't have this little enzyme that will allow you create that little protein that has an impact on your brain. So you don't see as much of the, like sedating effect or the kind of what's called an anxiolytic effect, so reducing anxiety, and probably not as much of the neuroprotective effect, the protective effect on your brain either. So the reason we would use a vaginal approach is some people, and depending what you read, it could be 10%. I know the International Menopause Society quote a much lower, like 2 or 3% of women. Anecdotally, I feel it's closer to probably 10% of women are really sensitive to taking micronized progesterone. And they might feel almost like paradoxical, like they get the other, they get worsening anxiety. It makes them stay awake. They go the other side. And so they would do better with the vaginal approach.
Yeah, I've heard of, women expecting to get a great night's sleep because in fairness, it's known for that, but there's always a small cohort. It does the opposite. And it must be just genetics, isn't it? Whatever way we're wired individually.
The same with, like, you think of PMS, we all have experienced some degree, but why do some women get much worse PMS than others? Like the studies would suggest you have the same change in your hormone levels, the same drop in hormones as everybody else, but some women are just really sensitive to that change, and that's probably genetic. And the same is probably true of progesterone. There are other options. If you're really sensitive to progestin or progesterone and you want to get that womb protection, obviously you can look at non-hormone replacement therapy options. You could look at, things that are like medications that are used for things like hot flushes, if that's what the problem is, but don't necessarily contain a hormone in them. Or something like Livial. I'm sure you've come across Livial.
That mimics the hormones, doesn't it?
Yeah, it's actually progestogen, just to really confuse people. If you're really being sort of pedantic and stick in the mud, it's actually a type of progestogen, but it interacts with estrogen receptors in your body as if you're taking estrogen. So it gives you some of that nice benefit. It'll definitely protect your womb. Can only be used by women who are post-menopausal. So you have to have gone that full year with no period before you can use it. It's not, it doesn't seem to massively impact breast cancer rates. So it'd be kind of similar to some of the safer progestogens in terms of breast cancer risk. It can increase your risk of blood clot or stroke, but only if you're over the age of 60 when you're taking it. So that's an option. And it's nice because it's all built into one little pill.
Fair enough.
The other option is
Sorry.
That's okay. Sorry, go ahead.
I have a question just to annoy you.
Yeah. Go ahead.
Mother Nature gave us 3 hormones, I think, for a reason. I'd like to ask her, but she's busy. When a woman has a hysterectomy, we obviously don't mechanically need progesterone. However, I know there's lots of women who do take progesterone anyway after a hysterectomy. And I'm just wondering, what's your opinion on that? And like, I don't know. And I mean, some people don't believe in the term estrogen dominance and all of that malarkey. And, I'm just curious as to, I just think some women who've had hysterectomies could really benefit from eutregestin. No?
Yeah, I totally agree. It's controversial though, like you pointed out, really controversial.
Is it? Why?
I think because the main purpose originally, the main purpose of prescribing the progestogen, the synthetic ones at all, was to protect the lining of the womb. And then from things like the WHI, the big study that was done back in the early 90s, they discovered that women who were taking only estrogen, so they'd had a hysterectomy, didn't need the second hormone, just took their estrogen, they had lower rates of breast cancer than women who were on both.
That's correct, yeah.
Now, you could pick this apart for hours. Like, there was so much wrong with that study and how it was interpreted and all the rest. The type of progestogen that they used in that study was a synthetic progestogen. It's not our lovely micronized progesterone.
Yeah.
Which we now know has a much lower impact on breast cancer risk than all the others anyway. So the current guidelines are, even though we know that progesterone, your body identical micronized progesterone, has all of these benefits and potentially really good health benefits, we're still not quite at a point in terms of health data on it to say safely, look, we should also be giving this to women who don't need it to protect their womb. We should be giving it just for those protective benefits. I suspect if you had a crystal ball and we could go 5 years down the line, I reckon we will be prescribing progesterone for women without their womb.
Yeah.
But it will have to be the micronized progesterone form,
absolutely,
not the others.
Yeah, I just often wonder, some women have hysterectomies and they do really well on estrogen only. Happy days. And there's other women that they're okay, but they have issues like anxiety and so on and so forth. And aside from that, I just often think to myself, now you're the doctor, and my God, are they missing out here? Like, why can they not imagine, it would give them a night's sleep again, for example. It would calm them down.
I have prescribed progesterone in that kind of situation. And it's sort of it's a trial and see, because obviously poor sleep could be caused by a million different things. But if it helps, well, then maybe your benefit that you're getting from it outweighs the small potential risk that we know exists with micronized progesterone. And I think it's also important to just, since we've kind of touched on it, there are women who've had a hysterectomy for severe endometriosis, which is a condition.
Yeah, and it'll calm it, won't it?
Yeah, and so the guidelines would be we should really be prescribing progesterone or progestogen. It doesn't really matter, but you should be prescribing something for those women, even if they've had their womb removed, because they may have small little pockets of tissue identical to what would be found inside their womb, sitting outside, like in their pelvis or elsewhere. They've had their womb removed. Those little pockets of tissue, though, will still respond to that estrogen if they're on HRT. And so they should be protected from that. Yeah,
absolutely. I'm glad to hear you say that. Yeah, and the future might be very different.
Who knows? Yeah, there's lots of things coming down the line. So the other thing that might come in is a thing called a TSEC. Have you come across a tissue selective estrogen complex? So
yeah, go on.
They're more commonly used in North America, but I think they're hoping to have them like licensed in Ireland and brought in to Europe, hopefully. So TSECs are a really good option for women who are very sensitive to taking progestogen or progesterone. And basically it's a combination of an estrogen combined with another molecule, a thing called a SERM, which basically is going to do what it sort of mimics what a progestogen does. It'll go in and protect your womb without having any impact on your breast tissue.
And this is going to be available soon.
Don't quote me on the soon bit, but I know it's something that's being looked at. Yeah, that may come in down the line, and it will have most of the benefits of your kind of standard HRT. But it'll be particularly good for women that might be progestogen sensitive. Yeah.
Excellent. Yeah. No, it's great to hear new stuff coming, and surely there's going to be more than Utrogestin in the future, maybe. I mean, because Bessons are the only ones making that, aren't they?
Yeah, and there were problems with supply, I think, at one point as well. I mean, it's so frustrating because we don't have an alternative when it comes to the body identical, that finding that molecule of progesterone that is exactly the same as what your ovaries are producing. I don't have a backup,
Yeah, I know. You prescribe the 100 milligram all the time. Yeah, I see some women get given the 200 milligram. Now, I know it's the same stuff, but I think that's marketed for IVF, wasn't it?
Yeah, in actually much bigger quantities. So for IVF, you might be using 600 to 800 milligrams of that progesterone per day. It's a lot. But for women who are taking it just for the 2 weeks out of 4, one way you can do that is to give them that higher dose. Yeah, they can take the 200 milligrams a day for 2 weeks, for 10 to 12 days, but for everybody else on continuous, they're taking it every single day. They would take 100. Yeah. Yeah, so it's exciting.
Yeah, it really is. This is fantastic information. Can I ask you questions that's not progesterone related, please?
Shoot. Fire away. I'm on the spot. Go ahead.
Can you please explain as briefly as you can to the ladies that testosterone can convert to estrogen?
As briefly as I can. Yeah.
Half an hour.
Okay. So basically, most of your hormones come from cholesterol, just if you want to pair it back to kind of where we start. And you get cholesterol from different sources in your diet and etc. And you then make, for a lot of them, you'll make testosterone out of that. So your enzymes work on it and make it into testosterone. Testosterone can then be made into progesterone. It can be made into estrogen. It can be made into other hormones as well. So it's a precursor hormone. So it can be made, we have enzymes that go and act on that testosterone and they convert it into estrogen. There are different forms of estrogen, remember?
Yeah, the 3 E's, yeah.
Yeah, so you have estradiol, which is what your ovaries make. That's what's in most of your body identical HRT. So again, Emeril Conti, Femiston, all of them, they're all estradiol. That estrogen that's in them is exactly the same as the estrogen that your ovaries produce. But we've other estrogen that we make when we're postmenopausal. So they come from fat cells that live usually across your stomach. That's why a lot of people put weight on across their stomach in menopause. And that's estriol. And then there's estrone, which is in pregnancy. Yeah. And they're working on a new type of estrogen called estetrol, which is also commonly seen in pregnancy, but might be useful in HRT. So not all estrogens are the same either. It's a confusing business, isn't it?
Yeah. No, I know.
But anyway, yeah, testosterone in a small amount can be broken down to estrogen. Yeah, 100%.
Yeah. No, it's just that I've seen maybe women who've been put on testosterone and they're feeling worse, and I think it's very suggestive that maybe it's converting. And can you tell me, like, why do some people convert and some don't?
Probably genetic as well.
Yeah.
There's probably a predisposition because everybody does convert it, but it's probably just to varying degrees. So it's more to do with the amount that you're converting, but we're all able to. Yeah.
Yeah. Okay. Interesting. Yeah. Okay. Thank you. I just want to clear that up because there's been a little bit of no, that's nonsense. It doesn't convert, and yes, it don't. No,
it does.
Anyway, thank you. There's a couple of questions here for you, a couple of statements. Hang on. Sorry, Kiva. I won't keep you much longer.
I could talk all night about HRT and menopause. So shoot, yeah.
This lady's saying, I have the coil in, but I have joint and breast pain, also night sweats. Oh, hang on. Now she's gone missing. What do you suggest? There you go. What would you recommend with body? Yeah.
So it depends on what you're looking for out of this. Like, are you on? Do you have a coil because of a need for contraception? Do you have a coil because of a history of very heavy periods or heavy bleeding? Could the joint pain be due to something else? Is the breast pain due to something else? Certainly if somebody is having night sweats or anxiety, that would be suggestive that their estrogen level might be a bit low. But again, you'd need to look at a sort of general overview of everything. And sometimes you can give a progesterone like Uterogestin, your body identical, in addition if somebody has a coil in. It's not sort of one instead of the other. So if somebody comes to me and they want, they're 49 or 50, they've been having periods up until recently or whatever, but they still need contraception, you can give your normal HRT, so estrogen through your skin. They're taking their body identical progesterone at nighttime to protect their womb, but they still need contraception. So you can prescribe a separate contraceptive pill for that too. Yeah. So it comes down to what your goal is,
Okay. Most of these are actually just comments as opposed to questions. Everyone thinks you're wonderful. Okay. I don't know.
Hit me with a hard one. You gotta make me work for it.
Okay, I'll give you a hard one. Histamine intolerance.
Oh God, why did I open my mouth? Yeah.
If you have histamine intolerance, are you less likely to convert testosterone into estrogen? If you have histamine intolerance, you need to keep your estrogen managed really well, don't you? You probably, this isn't really your area, Kiva, is it?
No, because histamine intolerance is such a new, it's something I need to kind of get more involved in. It's new really in the thinking, in the exciting world of menopause, but that's not going to change how you convert testosterone to estrogen necessarily.
Think so, yeah.
But I agree, I know there obviously is a relationship between estrogen levels and potentially histamine intolerance. And so that would be, something that you'd need to keep a close eye on. Similar to, I suppose, women with a history of breast cancer, prescribing testosterone, you need to be conscious of the fact that testosterone can convert to estrogen and therefore have an impact on their risk.
Exactly. And if you're trying to keep a lid on your estrogen to a point, I suppose you need to be careful, don't you? And interestingly, because this is Progesterone Monday, interestingly, micronized progesterone calms histamine, which is wonderful. And I've spoken to some women that are under experts in this area, and they'd be on much higher doses of Eutrogestin to calm
Really
things.
interesting. Yeah. Okay. Yeah.
Yeah.
What doesn't it do? Like, it's the little magic.
Exactly. Do you think compounded progesterone will be available in Ireland? Well, it is, but that's not recommended. Compounded is bioidentical. Yeah.
Yeah. So no, I yes, it's available. No, I don't think it's ever going to be approved, and I don't really think it should be. Sorry, let me rephrase that a little bit. Again, it depends what you're using it for. So let's say, if you're someone who's had a hysterectomy and you want to use your compounded, so compounded bioidentical just means that this is made, it's not sort of made in a lab, like it's usually made up by somebody, and it's usually a cream, so it's usually through your skin. And the reason that we don't love using the micronized progesterone, your body identical progesterone through your skin, is because if you remember when we were talking about that enzyme in your stomach, made by little bacteria in your gut and your stomach that breaks your progesterone down, that exists in like really wildly varying concentrations from woman to woman in their skin. So when you apply it, I don't know how much of that progesterone you've actually managed to absorb. So I don't know, are you getting enough to protect your womb? And that's why, the North American Menopause Society, the British Menopause Society won't stand over us using it, because we don't have enough. We're not definite enough that it's giving you protection to stop you developing abnormal cells. But if you've had a hysterectomy, so you don't have a womb, and that's not why you're using it, maybe there's a role for
you might get some
bioidentical
beneficial properties,
maybe, but again, controversial, but certainly not for womb protection.
Okay. If you're using Eutrogestin cyclically, okay, here's one for you, Kiva. What percentage of women will get uterine hyperplasia?
Yeah, so if you're using it cyclically, that's a really good question. So a really small percentage is the answer to that. What's interesting is with the cyclical approach, and the reason it's hard to answer is because it depends on other risk factors. So women with a BMI above 30, women who've had no pregnancies ever, women who have a family history of womb cancer, and there's a whole, women who smoke, and a whole list of other things, are naturally at slightly higher risk of getting womb cancer anyway, the way we all carry risk for everything.
Yeah.
So there are other risks at play here. But the cyclical approach, so giving it every 2 weeks and then taking a break for 2 weeks and going back on it for 2 weeks, it's a really, really small percentage. So you're probably talking only 1 or 2% over a long period of time. What's interesting is with the continuous progesterone, if you're taking it every single day, your risk of womb cancer is probably lower than someone who's not on HRT at all. Like, it's so effective at protecting your womb that the risk is probably lower.
And isn't the coil have the added benefit of less uterine cancer too, the Mirena coil? Yeah,
it's really effective. Some of that might be because we're all human and you might forget to take a pill here and there. And, whereas with the coil, you can't be non-compliant with the coil. It's
you can't really take that in and out every night. No.
I mean, you could try, but so that's probably why. Yeah, the coil is very effective as well.
Okay, here's another one for you. Now, I'm due to get the coil. You can see it there, actually, can't you?
Due to get the coil replaced after 7 years, would you get replaced or use a tablet? I'm 49 and don't need contraceptive. If I get coil, okay. So number one, my first question would be, do you need contraception? And she has said no, so that's great. Number two is, when you get your coil out, if you're only 49, are you going to start having periods again? And no one can answer that for you until you actually get your coil out and have a look. Yeah. And if the reason you had the coil put in the first place was because you had really heavy, painful, problematic periods, maybe you might be better getting another coil in potentially. And then again, going back to like, are you someone who it bothers the thought of like having to take something every day, or is it just easier having a coil in? So it comes down to that individuality. Certainly, if they got a coil replaced, if they got a new coil in now, and you're using it to protect your womb from estrogen, you can't leave it in for more than 5 years without getting it changed or going on something else. So she can't leave it in for another 7 years.
How long does the progestin last in the coil? Is it 4 years or 5?
It lasts probably 10 years realistically, or 7. The progestin, yeah. However, looking at the data, we know it will give you, if you're over the age of 45 when you have it inserted, you get 7 years where it's high enough of a dose to protect you from pregnancy. From protecting your womb point of view, you get 5 years. They used to say 4, now they say 5.
Gotcha. Okay. Yeah. Here's a great one for you, Kiva. Should every woman be put on some type of treatment pre, mid, and post-menopause?
It's a bit of a big
I'm going to leave you with that
one. So I'm biased, is what I would sort of start with, because the reason I do this at all is because I see benefit to it. I know the health benefits. And so now is my answer. Like, what if you really kind of go down to the fundamental of this, what we know is that, now this person says some type of treatment, but if we nitpick and say, look, HRT, hormone replacement therapy of some type, if it's taken, through your skin, if you're taking micronized progesterone, for the vast majority of women, their health benefits that they get and the quality of life they get from it is going to outweigh the small potential risk. Not for every woman, but for most. I do think everybody should be on some sort of treatment if they're having symptoms that impact their quality of life. It doesn't have to be HRT. Don't put up with symptoms, though.
What do you say, though, Kiva, there are women who actually do sail through menopause. Mm-hmm. And, as I was told once, I was very lucky I had symptoms, which I didn't understand at the time, but I understand now why. And I suppose what that lady is asked as well is, and I know you're biased, and I am too, but I always think we'll thank our future self, our older self. I mean, I know, like, I'm reducing my risk of heart disease by taking HRT. I'm reducing my risk of dementia, of osteoporosis, of incontinence, even some forms of cancer. And it's a very difficult question to answer. As a doctor especially, you can't tell anyone what to do. And I suppose, as we always say here at the Irish Menopause, is please inform yourself and make sure your decision is an informed decision and not just on hearsay or such and such up the road or around the corner said it's, we're going to be living longer without our hormones than we did with. And the female body doesn't do well without them. So that's worth considering, is it not?
Yeah, definitely. I think, like you pointed out, it's midlife health is really what you're looking at. And I suppose the lucky bit of that is that, if you're symptomatic, you're more likely to speak to someone and maybe more likely to then address, like I do cholesterol checks. We look at thyroid. We talk about breast cancer screening. We talk about osteoporosis screening with the DEXA bone density scan. We talk about cervical screening, STD screening, contraception. You talk about your long-term cardiovascular health, your long-term bone health, your risk of dementia, and so on. It's a really good point in your life because we know those risks change as you naturally lose estrogen. So it's a really good opportune time to have that discussion, and go through all of those risks and try and maximize what you can for your health. But it's also quality of life. Like you said, there's so much living to do after menopause. So it's important that you enjoy it, like that and you're not limited by symptoms that could be treated.
Exactly. And of course, I'm one of the ones I'm really scared of, and I don't know why, it's just osteoporosis. And it's silent as well. And we need to be aware of this because I think a lot of women don't know they're at huge risk of that because of menopause, let alone anything else.
Yeah, it's huge, actually really common. So, like 50% of women are going, yeah, exactly. Yeah. And then I remember when I was in college learning about the statistics around osteoporosis and my eyes almost kind of fallen out of my head because it's not something it's not a really sexy condition. It doesn't get all the kind of coverage. But if you have an osteoporotic fracture, you can, number one, the rates of morbidity, like the impact it has on your ability to be independent, your pain, the potential for chronic long-term pain, and death, the risk of mortality after, in particular, a hip fracture above a certain age. It's much bigger. Like, it's almost scary to talk about it. But even other things like the loss of, just the loss of your, day-to-day comfort. You can lose vertebral height. My poor mother has osteoporosis, and she has she has, her back is affected by it basically, but she's chronic pain in her back that comes and goes, and it's avoidable potentially, so vitamin D, really important. Everybody should be taking their vitamin D, and weight bearing exercise, which I can't ever manage to do, but I know I should be doing it. So get out there and go for a run. Yeah.
We just fly through some of these questions. I won't keep you on it. Are you at higher risk of uterine hyperplasia when you're on a higher dose of estrogen compared to on a low dose of estrogen?
Yes.
Okay.
Potentially, yeah, you are up to a certain point. So we know up to about 100 microgram, the equivalent of 100 microgram patch, 2 milligrams of an oral estrogen tablet, or what's the other one? The gel. So 4 pumps of gel. Now they're not exact equivalencies, but like give or take. You're going to get enough protection to counter that amount of estrogen, probably, with the standard doses that we use when we're prescribing progesterone or progestogen. Above that, though, we need to look at other risk factors and consider whether this is a woman that we need to prescribe a little bit of extra progesterone for.
Gotcha. Okay. Womb, ovaries removed, went straight into menopause for a few years. Now I have recurrent UTIs, etc., on antibiotics. It's menopause, and please see a menopause specialist if your GP isn't recognising that.
That's rough. Surgical menopause is rough. It's rough. It's a tough one.
Kiva, it's not funny. We speak to women in surgical menopause and they're told they'll be grand, no HRT. It's just shocking. It's shocking.
Yeah, because it's a kind of falling off a cliff effect, you know. It's
and natural menopause is brutal, so I can only imagine what surgical is like.
Yeah, absolutely,
This lady's on Vagifem and still gets UTIs, so she probably needs to talk to her doc,
Yeah, actually worth pointing out, maybe, just since you brought it up. So Vagifem, although it's estrogen, you don't need a second hormone. You don't need that progestogen or progesterone to protect the lining of your womb. Not enough of that estrogen that's in your Vagifem is going to get into your system, and it's not going to increase your risk of having cancer in your womb, which is good, obviously.
Great. Here's another one. If you have cysts and fibroids, is it best to get the coil to stop bleeding?
So the coil is a good way of treating heavy bleeding, absolutely. In terms of fibroids, it depends on where they are, how big they are. So sometimes they can actually be an obstruction when you're trying to get the coil in. So it depends on where the fibroid is and how big it is. Depends what you mean by cysts as well. So levonorgestrel, that synthetic progestogen that's in your coil, can actually increase the number of ovarian cysts that you get. It's one of the side effects. Small risk, but possible. So something I would usually counsel women on.
Okay. I think we've gone through them all, Kiva. God, you've covered so much. Thank you. Really appreciate your time.
Pleasure.
But listen, how long for the patch to work? There's a question for you. Tuesday week. It'll
how long for the patch to work? I'll usually, it depends what you're trying to treat. So if it's hot flushes, I'll usually tell people, look, if we have you on the right dose of estrogen, it's probably going to kick in the next 2 weeks. You should see an improvement within 2 weeks. But give it 12, give it 3 months before you really make a decision on it, you know. Individual, unfortunately.
Okay, and if 100 milligram of utrogestin is the lowest, what are the chances of having adverse reactions to it? Is there an alternative? Well, there's no alternative to utrogestin. It's the only one of its kind. What does she mean? Sorry, I'll just show you that comment. There you go.
So 100 milligrams is the lowest dose that we would use. You can reduce the length of time that you're taking it for. So you can reduce it down to about 12 days per month instead of 14 days per month. Or some women do a thing called long cycling. So they take estrogen on its own for 3 months. Then they do 2 weeks of estrogen and their utrogestin at the same time. And then they would get a bleed usually at the end of that. I'm not a fan of long cycling because we should really be following these women with ultrasound. So we should really be scanning them every 6 months or so to see how their lining is responding to that continuous estrogen on its own. And the risk is probably higher in terms of developing abnormalities. You're just not getting enough of that progesterone to protect your womb. Another alternative then is, like we had said, you know, to look at, I think, something like Livial, look at an intrauterine device, look at non-hormonal alternatives. So there are, but like usually you can change someone from utrogestin to something like Femiston or Everil Conti or whatever it might be, or even Dufaston on its own. You can change them to a synthetic progestogen to see, do they, you know, are their side effects more tolerable if they have had an issue with utrogestin? Do they feel better on an alternative? We're all totally individual. And the way I react to progesterone might be different to how you react, and so on. And one progestogen So one of the other synthetic ones might actually suit me better and I feel better on it. And I'm willing to take that small increased risk of breast cancer or that small increased risk of blood clot because I'm otherwise extremely low risk. So, so it's really individual.
There's a lot of trial and error with HRT, sadly.
Totally.
It's not like a Panadol, the headache will be gone. But, lots of women get lucky and
Yeah.
And like you say, flushes and sweats go very quickly. And am I right in saying that the emotional stuff, anxiety and panic attacks, always take the longest, sadly?
Definitely. Yeah. And you could pick that apart as to why that is. And especially, I think, in the last year with all that's happened, it's so multifactorial. There's so many reasons why we all get down and feel anxious and the constant news cycle and the whole thing. So it's not necessarily as simple as just being hormonal, although that's certainly a huge role. I know. Yeah, it's complicated. We're complicated beings, really, aren't we?
Aren't
we're complicated.
And no two of us are the same, and there's no two menopause stories.
It's great. Keeps us on our toes,
Absolutely. Every day is a school day. But Kiva, before I let you go, I'm sure everyone is welcome. I want to go and see her. So where can you be found? How does one make an appointment with you?
Yeah, so if I would love that. If women are interested, they can email info@menopausehealth.ie. And then I will get back to them. I'm hoping to start booking people into my schedule from next week to make an appointment. The clinic will be based in Dalkey, but I'm happy to do remote consultations, so by phone or by video, depending on what suits people. We'll be doing an array of different things. So obviously, consultations for menopause or hormone health in general, and then I'll be doing. So I suppose it's midlife health, really. Looking at screening, doing blood pressure and thyroid and cholesterol and whatever else needs to be done. I'm going to be doing hopefully IUD, so Marina-Coil insertions, removals, Implanon insertion and removals if people are familiar with the progesterone bar that's used for contraception, STD screening, cervical screening, and then I'll also be doing endometrial biopsy, so where we sample some of the tissue inside your womb. That's for women who maybe have some irregular or heavy bleeding on their HRT, and we just want to check everything is okay. And I do a lot of vulvovaginal health as well, and as part of that, sometimes women need a labial biopsy, where again we take a little sample of tissue from their labia. So they'll be the procedures that we're doing as well. So yeah, should be exciting. Looking forward to it. I'm going to be doing some training as well through the British Menopause Society, helping people, GPs or gynecologists that are British Menopause Society members to, become fully accredited. Yeah.
So you're British Menopause Society accredited and North American Menopause Society accredited.
That's right. Yeah. I'm really straddling the ocean there. Well, you'd hope at this stage, wouldn't you? So,
I don't know what to do.
Look, proof is in the pudding. Time will tell,
Absolutely. Stay where you are, Kiva. And ladies, thank you so much. And I'll see you all later.